The disclosures specific to me are non-existent. I am a transplant nephrologist at the University of Kansas, so I am trained in internal medicine, in nephrology, and in transplantation. And a lot of what I do on a day-to-day basis clinically is to manage patients with kidney transplants or other solid organ transplants. So I take care of patients that have had kidney transplants, liver, pancreas, heart, and some bone marrow transplants as well. So there's a lot of interaction and intersections of medical care that take place over time, depending on someone's journey. And as such, people like me are trained to help. I do have a fair number of research projects, some of which are oriented toward biomarkers in transplantation, looking at kidney injury and rejection. I've also done studies into frailty in the kidney transplant space. The objectives here today are to find ways that are instructive as far as the management of post-transplant care to optimize your lives and your quality of life, and make sure that the kidney transplant works well in the years ahead. We'll also list potential challenges and complications that are commonly associated with kidney transplant care. Part of our purpose is to identify reasons why working with a transplant center like ours after the release is important and can be beneficial to optimize care. The outline today is broken into really 4 parts. The first 2 are the crux of this. So we're going to identify care after kidney transplant and the role of a primary care physician, or what I'll describe as local care with a context of feeding back to the local center, as well as PKD-specific processes, so intracranial aneurysm screening and liver cysts. To start, the first kidney transplant recipient at the University of Kansas was Miss Allen. She was only 30 years old when she had developed advanced kidney failure. She was believed to be healthy up until 1969 when she presented with a seizure. She was actually living in Syracuse, Kansas, which is in the Goodland area. This is not far from the Colorado border at all. And she presented with severe kidney failure. She had a creatinine over 20, and she's a tiny lady. She did stabilize out her clinical course with dialysis, but transplantation became a question, and fortunately, her sister was actually available to donate an organ. This was an important and newsworthy moment in 1969. July 28th was the donation and transplant surgery, and the local papers had a lot of reporting of this, both about her sister doing well with the donation and the kidney transplant recipient, Miss Allen, doing well in the early days after transplant. The amazing news is that in 1999, there was actually a reunion at the KU Center, and Miss Allen is shown in the middle in the white blouse. This was at the 30-year mark with excellent kidney function, and her sister Esther is shown in the floral blouse, still in good health with no identification of any kidney disease. And actually, to describe other individuals in the picture, the nurse coordinator in the black blouse was the first transplant coordinator at the University of Kansas, and she worked there for 40 years, handing that torch to other people that I still work with. So it is, I think, generationally pretty remarkable that kidney transplant has gone on. This was only 50 years ago, and already there are these connections into the past that persist. The amazing things within transplant are how much Miss Allen has taught centers like ours, that she lives in Syracuse, Kansas, with local physicians there. There were no local nephrologists in 1969, so a lot of the care happened through our university. But Miss Allen was only 30 when she was transplanted. She went on to need other things that women need. So she had pregnancies after transplant. That care was followed by obstetricians locally and at the University of Kansas. She delivered via C-section at our university. So a lot of the care that we learn in interweaving interdisciplinary factors are what patients show us, that we're here to help and put our heads together and blend care where possible. But with communication through our center, we're usually able to optimize that care. The kidney transplant story is one that I think has good data as the treatment of choice for kidney disease. Dialysis is a way for people to get through with advanced kidney failure and ideally can bridge to transplant. The risks are not zero in coming off a wait list, off stable dialysis, and pursuing transplantation, but that risk is generally offset about 100 days into transplant. So by the 3-month mark, patients are typically going to have offset that risk of coming off a wait list, taking the surgical risk, and going through the transplant process. And really, any months after that, the survival risk gets better and better. And after that, the quality of life is usually the part that maybe sticks out for patients in balancing that debate between dialysis care and transplantation, where it isn't a cure-all. We reset the kidney function to a normal or near normal number. However, patients are required to take medications for the rest of their transplant life. And as such, there are balances that have to be decided between transplant centers like ours, between patients and caregivers, and what makes sense for you guys going forward so that we can be as helpful as possible as individuals that oversee the care. Are we good so far? Okay. So to throw a little bit of data at you, the kidney transplant data continues to look better decade on decade. So a deceased donor transplant these days, meaning a cadaver kidney, someone that is on a wait list and is offered a kidney from someone who has died, those kidneys last now a median of 10 and a half years. So all comers, 10 plus years of kidney function is stellar, and living donor transplants last somewhere in the 12-year mark. This can be substantially longer. Miss Allen, as I showed, is now 54 years at a transplant. Her creatinine is lower than mine. So there are absolutely scenarios where people live past what our metrics entail. And additionally, what I'll maybe show at the top of the slide are the patient survivals, which now are usually measured on decades, where patients really have a blend of care in kidney disease, something between advanced kidney care, dialysis, whether that's hemodialysis, peritoneal dialysis, and if possible, will transition to transplant. And as that transplant is waning, patients may actually get a second, third, fourth kidney transplant. They may need dialysis in between or at the end of their life. And as such, this really is a blend of kidney care over time to optimize someone's quality of life and hopefully extend their survival so they can enjoy all the things in life they want to do, whether that's taking care of grandkids, whether that's going back to work. These are all considerations that we have in trying to promote the quality of life for individuals that are pursuing transplant. And there are absolutely risks in getting to that part of transplant care. However, it's our understanding as we follow people over time to better gauge those risks and benefits so that we can optimize the decisions. Kidney transplant itself does require close follow-up after transplantation. Patients are on complex immunosuppression. They're generally more susceptible to infection, to cancers, cardiovascular disease. And a lot of our role before transplant, for anyone that's sat in those conversations about evaluation for kidney transplant, these three things are what we are looking at probably in a primary role with individuals that may have underlying cardiovascular disease, they may have an infection history, or prior cancer history. And as such, a lot of what we're doing is evaluating those past histories so that we can optimize care afterward. Additionally, patients go through pretty standard protocolized approaches at most centers to evaluate cardiovascular disease. So patients are going to get heart tracings with an EKG, they'll get ultrasounds of their heart with an echocardiogram, they may get stress tests, either running on a treadmill or doing chemical tests. And those are all ways to evaluate the heart. And a lot of those risks that maybe we identify going into transplant need to be evaluated in subsequent times after transplantation to ensure that people are safe, that their infection risk is mitigated, that any cancer risk is optimized, and that cardiovascular disease is followed longitudinally. So in addition to all the things that we evaluate, I would just say that patients that have comorbid illness, meaning diabetes, obesity, high blood pressure, heart disease, are things that may be the cause of end-stage kidney disease or may be part of the story. In a scenario of polycystic kidney disease, fortunately, many people know about their polycystic kidney disease long before they encounter end-stage disease. As such, I would suggest that most people at this conference are stewards of their own care. They're careful and mindful about how they approach their day-to-day life. They observe diets that are adherent and cautious. They exercise and don't smoke or use other substances that may change their kidney function more dramatically over time. So a lot of the individuals that go after attempts to be good stewards of their body generally make really good transplant patients because a lot of the things that we individualize and optimize before transplant, you're going to be doing autonomously afterward. The kidney transplant care is complicated. So our centers will focus on things like the immunosuppressive drugs, the drugs that lower your immune system to tolerate a kidney that is placed in your body to restore function. The kidney function is something that is an ongoing question after transplantation. Our job is to assess the technical aspects. This usually involves a transplant surgeon and a transplant nephrologist to help optimize how that kidney works, and medically, how to determine what that kidney needs so that a patient can do better longer. Fluid management is an ongoing assessment, as well as the preventive antibiotics that are generally protocolized at a center. There is treatment commonly of infectious complications. These are mostly foreseen within that long informed consent you sign, but a lot of this is protocolized as a center to try to figure out how to optimize care and look out for the things that we know may be lurking. Blood pressure management, diabetes management are common attributes after transplant, where we may require changes in blood pressure management. The diabetic care is something that can happen. 10 to 20% of patients after transplant do develop a new diagnosis of diabetes. And as such, a lot of our management goes back to those really basic conservative measures of diet and exercise, as well as new measures with different medicines that are available, particularly if kidney function is restored to normal or near normal. We have a lot of opportunities with a long arsenal of medications that we can use instead of just things like insulin. Anemia management is a large part of the story within kidney disease itself, and it's an ongoing portion of the management in the early transplant period, as well as some of the parathyroid optimization that can be a struggle around the dialysis period and in the early going after kidney function is restored with a transplant. To focus in a little bit on the immunosuppressive drugs and the kidney function, the immunosuppressive drugs, by and large, at centers are three. So prednisone is a steroid. It is used at virtually all centers. However, about a third of centers like ours at the University of Kansas do have availability, depending on patient characteristics, to avoid prednisone long-term. There are advantages and disadvantages to that. The high doses of steroid over time have adverse effects. People can retain salt in water, blood pressure can be higher, blood sugar is harder to control, there's weight gain, can change bone health over time. And as such, we try to get away with as little steroid as possible in the early period after transplant. That's usually protocolized and weaned off in patients that are low risk enough to do so. And we'll usually use the other two drugs. Tacrolimus is a subtype of calcineurin inhibitor that is commonly used after transplant. And its ancestor, the original drug cyclosporin, really changed the landscape of transplantation. So prednisone has been around since 1950. We've been using that for transplant forever, but that used to be essentially our only drug besides azathioprine. Cyclosporin came around in 1983, and it cut rejection rates from 50% to 20%. So it dramatically expanded the lifespan of kidney function, and it permitted us less reliance on prednisone over time so that patients had fewer side effects and more optimal quality of life. The drugs like tacrolimus can be followed with drug levels. High levels tend to cause lots of side effects, salt and water retention, high blood pressure, tremor. There can be neurologic effects with insomnia and nerve discomfort. So we have to follow closely to make sure that we don't run into more adverse effects with this drug, and that's why the monitoring piece is so critical. Some patients are not optimal for this drug, particularly older individuals. We can run into a lot of cognitive changes where people don't think as clearly, they don't walk as well, and we may need to optimize this drug, either by lowering it, changing it to different agents. And as such, a lot of the tinkering that we do outside of protocol is to really offload some of the side effects people encounter. Mycophenolate is a commonly used drug. This is one that can modify some of the DNA that you make. And Cellcept and Myfortic are those two classes of drugs for those that have been around individuals that are on these agents. They're commonly used. There can be side effects in cell counts, so we end up adjusting the doses. Same thing with a lot of viruses that can pop up after transplant. We tend to adjust this drug over time or stop it entirely if we run into issues. And preventive agents. These prophylactic agents are usually for viruses and bacteria. So cytomegalovirus, herpes viruses are usually agents that we're trying to prevent with these drugs. However, their doses sometimes need to be modified based on kidney function or the interaction with other medications people take. And the same thing with antibiotics that patients are on for a preventive measure over set periods of time after transplant are in place to prevent lung infection with things like pneumocystis, stent infection, and urinary tract infections are some of the common issues that we may identify after transplant. Are there any questions so far? Okay. So kidney function is really the primary assessment of a kidney transplant center, and a lot of those attributes that we think of for a kidney transplant center are trying to optimize how that kidney works. Some of the technical pieces are usually anatomic. We're at a PKD conference, so this is a PKD patient that I take care of, and maybe noteworthy here are this liver has cysts in it, so this is probably someone with AD PKD. These are their kidneys, so very large polycystic kidneys. And down here in that yellow oval is actually the kidney transplant. So this kidney transplant is pushed all the way down into the pelvis. The kidney transplant sits down either in the right lower side or the left lower side, down around that pelvic bone that you have. And so a lot of the considerations, and maybe you were in other talks about this, for how polycystic kidneys crowd out that surrounding space in the belly cavity are a conversation we have in the committee to determine how much space is available to put a kidney transplant and where to optimally place it so that kidney transplant has the most room to work, so to speak. So that technical piece is probably the biggest one of figuring out, are these polycystic kidneys going to stay for the transplant? Do we need to take the kidneys out beforehand? Are people having such symptom burden after transplant that we need to pursue nephrectomy? Those are all patient-specific guidelines. You're not going to run into a lot of clear identified guidelines. It's really going to be patient-specific, and the technical part is the initial piece. For patients that have a second, third, fourth transplant, a lot of these arterial and venous anastomoses, the connections between arteries and veins, become more of a question of where a kidney transplant can be placed safely and optimally. The ureter is the P tube coming down from the new kidney, and it has to be attached into a patient's bladder. So we follow those considerations over time, as well as fluid collections, which happen in virtually anybody that we scan after a transplant. This can be a, quote, normal fluid that comes out. These are seromas usually. Patients may have blood, and these hematomas can drain or may need to be drained. There can be infectious pockets, and also the lymph tissue that's cut around that iliac fossa can drain and create large pockets of fluid that can affect the way a kidney functions. So, yes, ma'am.
Why don't you just take the polycystic kidneys out when you put the new kidney?
Some centers do. To repeat the question, can you take the polycystic kidneys out at the time of the transplant? Yes. So this is done. Patients that are not on dialysis going into a kidney transplant, particularly a living donor transplant, if we have the opportunity to schedule out the surgery, we usually have to prepare for a long operation and someone that is ready to do it. This is a big incision, so it's usually something that goes from xiphoid to pubis, so you can open up that space and get both kidneys out and then optimally place a kidney transplant. So it's a big operation. Doing one or the other separately are big operations, and doing the two combined, I won't say that it's hero status, but it's a long recovery where someone needs to be ready to undertake it. Typically, a kidney transplant itself, someone's in the hospital for about 5 days. Most people that do bilateral native nephrectomies are in the operation for a good portion of the day when they do it, and they're usually in a hospital for a week or longer recovering. So if it is ideal to do so, where people are able to preserve enough kidney function to get to kidney transplant, that's something a center will do, pretty center specific. I will say that patients that are already on dialysis needing a kidney transplant, we usually will, if they're having no symptoms and doing well with dialysis, which a lot of individuals with polycystic disease, even on dialysis, maintain normal or near normal urine output. And that's a really optimal scenario for the dialysis itself. So sometimes if patients aren't burdened by the symptoms of having polycystic kidneys, then we'll actually do the transplant first, and in the 6 or 12 months afterward, talk about doing the nephrectomies. Does that answer your question? Okay. Sure. Big warning, not a surgeon. So, yeah. So from the medical perspective, a lot of what we're doing in the early going has to do with how well a kidney works after transplant. I am the medical director for living donation at our institution, so I am a strong advocate for living donors. We really like living donor surgeries. They're scheduled, we can optimize the care for donors and recipients, and the kidneys work right away and they last longer. So we really like those scenarios where patients are, essentially there's a donor in one operating room and there's a recipient adjacently. You roll that kidney over to the next operating room. The time on ice is measured in minutes. Deceased donors don't work that way. Kidneys are like babies, they just show up. And there may be time on ice, there may be time on a pump. So you really are stuck with whatever hand you're dealt in terms of what issues a deceased donor had, whether they had high blood pressure, diabetes, and how long that kidney is on ice or pumped before it gets to the recipient may determine how quickly it works. Some kidneys are slow to work, or they just kind of trickle in function and the urine output's okay to stay off dialysis. Other individuals have delayed graft function where they need dialysis in the first week, and it may take a couple weeks to clear up the function. And so a lot of what we're assessing in the days after transplant and in the weeks after transplant is how well the kidney works, what kind of fluid management someone needs. Do they need dialysis? Do they need diuretics? Do they need to get fluid back? Do we need to give people IV fluid? And a lot of the preventive antibiotics and the treatment we do is blended, looking at kidney function, how drugs interact, and trying to figure out how to optimize care and make sure that kidney works well for somebody. Hypertension is a pretty common condition for folks on dialysis or with late-stage kidney disease, and we do have ongoing management where patients come in with logs of their blood pressure and heart rate and weight, and a lot of that assessment week by week occurs just to tinker and adjust the blood pressure as we go. Diabetes care is, if the kidney function is good enough, then we usually have people that take pills for their blood sugar over time. We have a lot of patients that take some of the newer agents and some of the weight loss shots, both to optimize weight gain after transplant and to help with blood sugar management. A lot of the shots and anemia care that people need when they're on dialysis or late-stage kidney disease will continue in the early going with a kidney transplant, just to give it buoyancy and make sure that there's optimal footing to support what the kidney needs. So pretty complicated set of to-dos for a kidney transplant center, and we have a lot of specialists that help us. We have transplant surgeons, nephrologists, transplant-trained nurse coordinators and pharmacists. We have dietitians, social workers. We have people that specifically work in transplant finance, psychiatrists, psychologists, gift of life. There are a lot of people that are working within this space to help optimize care. So a lot of that early general care is through a transplant specialist, someone like me on the transplant nephrology side, perhaps a transplant surgeon, and we'll do a lot of the care in the months after transplant. That the first 3 to 6 months, we're doing a lot of the care. And every center is a little bit different on when that refer back happens. So we will sometimes have patients that at other centers may be referred back at month 3 or 6. We refer everybody back at month 12, or if they have lingering issues, we'll continue to manage at our center, perhaps forever. So to get to the crux of it, for patients that go back to their local nephrologists and local primary groups, we still are involved in the care. And a lot of this comes down to the communication with our center to make sure that there's optimal placement of medications and however that availability is needed. The advent of telehealth has been great for this, that we're able to follow patients over time and make sure that they get appropriate care. So if they live far away or have other logistic challenges, then we can see them virtually and help direct some of the care or update labs. And we really do rely on the local nephrologists, on the internists and general practitioners to assist wherever they feel comfortable doing so. So the transplant nephrologist may be directly involved in the care with the recipient for the life of the transplant. But when that isn't practical, then these other pieces fall in so that patients can get the care they need. And it's that ongoing communication between the local group and the transplant center that permits the ongoing care. And patients will just have long-term ongoing monitoring of their kidney function, their drug levels, and really their global health over time to make sure that these patients that are susceptible to infection, cardiovascular disease, malignancy are followed so that their comorbidities are managed. In addition to all the co-management on the transplant side, the high blood pressure, diabetes, obesity, high cholesterol that's managed really falls down to if there are providers that feel comfortable managing, then they work with our center and we find ways to blend the care and make sure that individuals get what they need so that they can have a better quality of life and hopefully better management over time. Health screening is generally done by age, and these are usually age-related guidelines. So we follow the American Cancer Society guidelines before transplant and afterward, and that's usually what we refer primary care folks to when they're asking questions about what to screen and how to screen. And vaccination, while it's not specifically within this talk, we avoid live attenuated vaccines, but flu shots, COVID shots, shingle shots, those kinds of things are all strongly encouraged after transplant, and the subtypes and such really just contact our center, and we have pretty common pamphlets and guidelines that we refer the care providers to. So we use the CDC guidelines for solid organ transplant. They're easily accessible online, and that's usually the go-to for information that is always changing just a little bit year by year. And again, it's really that communication between the center and local physicians that is the optimal portion of care. And this is just some of that screening guideline as shown, which already is out of date. So moving past some of the transplant care toward specific ADPKD extrarenal complications, cerebral aneurysm and hepatic cysts are the two identified things that we'll talk about. Pancreatic cysts exist in PKD, but they're generally benign and don't cause any specific damage at a function level. Hernia risk is something that exists with that crowded out space from PKD with peritoneal dialysis and other things, that there can be hernias that occur after transplant as well that have to be followed. Cerebral aneurysm is a subtype of an aneurysm, which is a ballooning or bulging of a blood vessel. And the issue is within the intracranial space. So about a 4-time higher risk with ADPKD compared to the general population. It's about a 10% of ADPKD patients. And the concern is when those blood vessels that go to the brain have ballooning that actually burst. So that blood fills other spaces around the brain, and the blood flow going to specific areas of the brain is no longer possible. So there may be oxygen deprivation to tissue. As such, patients can have mild or severe symptoms. They can have severe headaches, nausea, vomiting, loss of consciousness, even death. And as such, patients with PKD are recommended to do screening. And a lot of this comes down to what risk factors an individual may have at the personal history side, at the family history side with a first-degree relative. And particularly in female sex and over the age of 50, there tends to be a higher rate in a 2-to-1 ratio of cerebral aneurysm. And that's probably hormonally derived as the postmenopausal years set in, that there's probably more of a component that leads to aneurysmal change and high blood pressure. In one long-term study through the Mayo Clinic with about 800 patients that screened everybody for aneurysm, about 10% had aneurysms identified. These were more common in individuals with high blood pressure and smoking and family history. And the higher risk people with 7 millimeters or higher and other risk factors had clipping or coiling of those aneurysms. None went on to have rupture. There are actually 2 patients that didn't have any initial aneurysms on screening that had de novo change and had rupture. So this does describe that patients with stability over time and control of risk factors have lower risk, particularly if they're followed closely. The screening is generally done through magnetic resonance, so an MRA or a CTA, a CAT scan, and patients with a strong family history or personal history are generally recommended to undergo screening. The other considerations are folks in high-risk occupations or needing long-term blood thinners where perhaps that screening could be recommended. Initially, patients are generally going to have an MRA or a CTA, and then perhaps about every 5 years after that, if the patients don't have an aneurysm but have a strong family history, the role of screening is less clear in an individual with no family history and a negative screen. It's unclear whether we should pursue further imaging in those individuals. So the aneurysm rupture is really a risk by size, and greater than 7 millimeters is usually where you start to follow more closely. And if deemed stable over the first couple of years, we'll generally push out that interval follow-up. However, if someone has a new aneurysm, those are probably going to need to be seen about 6 months later on imaging to make sure they're stable before backing out the interval. So some centers will screen all ADPKD patients, some just base it on risk factors, and it can be variable depending on the center that you're working with. The idea in the early going is that if you know you have risk factors, have a conversation with your local physicians so that you can individualize care. touch briefly on liver cysts, liver cysts are common within ADPKD, about 85% of those 30 and above. And the liver cysts are generally larger and more numerous as patients age, particularly in women that either have had multiple pregnancies or some sort of hormonal exposure, contraceptive pills, hormone replacement for a prolonged period of time. And the fortunate news is that liver cysts generally don't cause symptoms in individuals. When severe, there can be changes of fullness or early satiety, maybe changes in breathing or pain. That's usually if a cyst ruptures or causes infection. But generally, the liver function by itself is not typically altered. Patients may need antibiotic therapy, in severe cases drainage or repeat drainage, and in really severe cases, those cysts can be essentially unroofed in surgery. And in really rare cases, patients may need a liver transplant, either because of very large liver or ongoing complications where they may need a liver plus kidney transplant. So I think that was it on my side in terms of the slides. I'm happy to open up the conversation for questions at this point, and I thank everybody for their attention. Yes, ma'am.
All right, wait for the microphone, please.
I was just wondering what your center recommends for an MRI or MRA of the actual kidney, the new one, and the old ones if they're still in there, like every 5 years, every 10 years after transplant.
Yeah. So the question was whether we do surveillance imaging of cystic kidneys after transplant. And the simple answer is we typically don't unless there's a change in symptom burden. So if patients are getting recurrent urinary tract infections or have a lot of pain that we can't explain, then we may do specific or individualized imaging to try to update. The selection between an MRI and a CAT scan is usually going to depend on the patient and what they may benefit from. So generally, we don't do the ongoing checks, which have a lot to do with looking at kidney size and volume over time that predict out some of the kidney function course for individuals. And the horse is out of the barn, so to speak, when people need a kidney transplant. So we typically don't worry on the function side. It's more of a symptom burden question.
All right, we have some questions online. Have you had experience with COVID donor transplants, living or deceased? Was the post-treatment different from a regular transplant post-op care?
So our center has been doing kidney donors that had COVID for almost 3 years. So we've transplanted more than 50 COVID donors. And our requirement in 2021 was that any individual receiving a COVID kidney had been vaccinated, just to mitigate some of that unknown risk of transmission. We have never seen transmission from a COVID kidney donor to a transplant recipient. There is at least one case report of a lung transplant COVID donor that transmitted to a recipient, but I don't have any individual stories on our side for kidney donors with COVID. The outcomes are good. The kidney transplants tend to work very well, depending on the scenario. These days, coronavirus has changed to a degree where a lot of the incidental COVID diagnoses are usually unrelated to why a person is donating.
All right, another question. Is there added risk to the kidney recipient for something like getting a tattoo after transplant?
We generally wait 1 year after kidney transplantation to green light tattoos. That's mostly, there's some data, depending on where you go, for the tattoo that you need to have essentially a sterile technique to do it. And so we try to wait to a year just so that the infection risk is lower. It's usually more of a skin infection risk. There's a theoretical hepatitis transmission risk with needles, but a tattoo parlor that is upstanding, if that exists, would probably be using new needles for every tattoo.
All right, next question. For post-transplant proteinuria, are the native kidneys ever a source, or is this usually due to the graft, and how is it ascertained?
Yeah, one of life's big mysteries. So for those that are fortunate that maintain urine output going into transplant, particularly in the early going when kidney transplants themselves aren't fully working and we rely on native function, it is very hard to tell the source because we're looking at the summation of all the urine output when you leave a urine sample. So we do other imaging. You actually can do fancier tests to see how much flow is coming from native versus transplant kidneys. So when we are unsure, we usually have to do some additional tests.
Next question. Are long-term transplant patients, 20 years plus, able to wean off one or more immunosuppressants?
Generally, yes. Miss Allen, who I take care of, is still on the same drug she was put on 40 years ago. Don't tell my medical director, but usually when things are not broke, I tend to not look for fixes. So patients that are doing well, which, if you're looking at folks that are that far out, we're usually reluctant to make a lot of changes. It is not uncommon to see patients that are on less drug over time, but there's not really a standard minimization. This is usually individualized. I have a fair number of patients that are on 1 or 2 drugs after transplant, none that are on 0. So maybe one day that will happen. But the most patients are on either 2 or 3 drugs after transplant, and a lot of it's trial and error. A lot of the times that people end on less drug at 10 or 20 years is because they had an adverse issue.
Is your clinic seeing any increased incidence of MGRS paraproteins in post-transplant recipients, and do we know the cause and how this is usually treated?
So for those that don't speak Greek, we're talking about protein that exists in the urine, and patients with advanced kidney disease can develop small amounts of protein in their urine over time. A lot of that actually goes away after transplantation. Don't know why, if it's the drugs that people are on to lower their immune system, or whether it's the return to normal function, but frequently a lot of the protein that we see in people's urine goes away after transplant. When it either recurs or happens for the first time, we tend to look for things that may cause that, whether that's diabetes, whether that's myeloma, and a lot of the consideration is usually specific for where that's derived. But I can't speak to whether we're seeing a higher incidence. It does not seem like it, but I'd have to look at our center data.
Someone asked if a transplanted kidney can start to develop cysts.
Yes. So some donors have cysts. Cysts are common with age, so you're allowed essentially a cyst per decade after the age of 20 or 30. So it wouldn't be uncommon to see a cyst per side in someone that's 30 or 40. And so yeah, sometimes people get cysts in their transplant kidney as well.
So I have a question. My transplant was 21 years ago, and
Congrats.
21 years ago they gave tacrolimus and mycophenolate with some prednisone.
I know, we're still pretty boring.
So is there no development in future more immunosuppressants?
There are actually a number of drug trials ongoing, and they're actually calcineurin sparing. We have a lot of patients that are on drugs called belatacept, which are infusions where people sit in a chair once a month and do that in place of the tacrolimus entirely. And so I have more and more people that are on those drugs and have good stability. And some of the people I mentioned that are on one drug, they're literally on an infusion once a month, and they don't take any pills for the transplant.
Any more questions here?
I'll keep this general, but it's a real-life scenario, not related to me. We know that various centers use different protocols with regard to prednisone. So this particular scenario is a person who was to be prednisone-free, but then due to BK load, medication was modified, prednisone was reintroduced. I learned this morning about the long-term use of prednisone, then the caution of withdrawal.
Yeah.
What's your consideration in that, looking at a 6-month-plus time frame? What factors do you consider about whether to totally take the person off prednisone as the BK is under control?
Usually, so I think everyone heard that, but BK is a virus that exists around kidneys that most people are exposed to in childhood and recover with a benign illness. And it's only kidney transplant recipients that happen to have the kidney tissue where that BK is stored start to replicate after transplant. So it can get in the bloodstream and into the kidney, which is why we screen people early after transplant to identify that virus. And unfortunately, there still aren't any slam dunk medications that we can use to treat the virus. So the most fair approach in terms of management is to lower the transplant medicines when we identify that virus. And so better to treat early than late. And the early modification of drugs sometimes means that we shift around or add agents because we're on such low doses of other ones. That is a really common scenario to see patients with BK in the first 2 or 3 months after transplant, typically up to a year. And it may take months to treat. So once the virus is eradicated or low, sometimes we'll start modifying those drugs again and perhaps take someone that was prednisone-free, have them on prednisone for a period of time, and then see if they can tolerate enough of the mycophenolate or other drugs that we can get them off the prednisone again. And again, it's competing risks. So low doses of prednisone, we're usually talking about 5, maybe 10 milligrams of prednisone over time, are generally well tolerated. There are individuals that don't tolerate it as well, but in the short period, there are usually ways to allow the immune system to heal so that we can introduce medicines that are stronger later on. I don't know if that answered your question, but it's pretty individualized.
Well, it was just in the context of a talk this morning about when it would be cautious to remove the prednisone from the protocol
Yeah.
due to a risk of rejection based upon the removal.
Yeah.
And again, I know you can't comment on a specific situation. I just
Right,
want your
right.
thoughts on it.
Yeah, definitely individualized in those scenarios, but it's anytime that you're modifying somebody's drug and reducing it from the kind of standard protocol levels, you do introduce the risks of having the immune system become more active. So it's something that we constantly surveil through various methods.